Now, when you have all these data analyzed, then the next step is looking at the instance of disease among the exposed, disease among the unexposed. So people who have diabetes in the first row, the instance of HCC will be A divided by the total, and the instance of people without diabetes will be the second row, C divided by the total, and then you can calculate the ratio of those instance figures, and that would be the equation for you to calculate the relative risk. So at the end of the day, you will be able to say diabetes increases the risk of HCC by so many fold or so many factors. So this is an example where hepatitis B was considered as a cause of hepatocellular carcinoma. It's a 20-year-old study, but it's still a gold standard. So this was a large community study, 11,000 people in Taiwan, and then they were followed for 8 years. At the beginning of the study, they determined who had surface antigen and who did not have surface antigen, and determined at the end of the day who developed hepatocellular carcinoma or not. So the first row here, instance among surface antigen positive, is calculated as we just presented in the past slide. And then people without surface antigen, that's 29 over 9,532. So the relative risk is 11.7 with interpretation of the number being that hepatitis B increased the risk of HCC by 12-fold. So that's beautiful. Very well done. It's accurate. But the cohort study has some issues. But advantages first. It's the only way of directly establishing the instance, the absolute risk. It has the strongest evidence of causality because we are doing a prospective study. There's accurate exposure data. You know at the time of, you're still doing the study, at the beginning of the study, you know who has diabetes or not. You're not doing a chart review, you're confirming that on day one. It allows to study the relationship between exposure and many other diseases. Once you have a cohort set up, you can not only look at hepatocellular carcinoma, you can look at other diseases that may be associated with diabetes. However, cohort studies are disadvantageous because it is inefficient. You need to have a large cohort. You will have to follow the whole city full of people to do the study. It is very expensive because of the large number of people and long duration of follow-up. Again, it is a lengthy study. And if you don't have the right exposure history at the beginning, then you cannot do another study. You follow? So if this is a diabetes, non-diabetes, that was your question, but you also wanted to find out if hepatitis C causes it. But if you don't collect hepatitis C status at the beginning of the study, you cannot go back and reassess that question. This is a cohort study. I'm just giving you a reminder. How about this study design? What if you went out into your community and collected a bunch of people with diabetes and collected a bunch of people without diabetes, and then you follow them forward for liver cancer or not? That sounds like a reasonable thing. But if you did that, the results are valid only if diabetes and non-diabetes patients are representative of the whole population. So if you did it correctly, this will be valid, but most of the time, it is very hard to do a valid study. This will require random sampling of stratified kind to make sure that the samples that you have are representative of the whole community. So that's uncertainty. The other problem is for the relatively low quality data that you will be generating, you will go through the same follow-up period and the study will be expensive. So this type of study is not recommended if you can help it. And that's in part because you can do something similar with case control study. So here you're proposing to collect patients, diabetes, no diabetes, and going forward to try to figure out who develops cancer. Case control study is backwards. Case control study starts with who has cancer and who doesn't have cancer. It starts from the right side of the slide. And then you determine who has diabetes and who doesn't have diabetes. So this is a sort of a retrospective identification of the exposure history. But once you have done the study, you come up with the same 2x2 table, A, B, C, and D, in this fashion. Generalizing it, cases are people who have disease. Controls are people who don't have the disease. A lot of times people get confused. When you say controls, they're controls without disease. Controls are not people without the risk factor. So these are not controls. Controls are over that side. Don't get confused by that. Cases are controls, and then you come back and figure out who had exposure and who did not have exposure. And then you can do the 2x2 table like the cohort study, except here the total column is not done because it has no meaning. Here you cannot calculate the relative risk as we did with the cohort study. What you get is odds ratio, A times D divided by B times C. The meaning of the odds ratio is very similar to that of relative risk. That is the utility of case control study that is done well. So this is an example that was done when Jorge Marrero was with Dr. Anna Locke in 2005. He identified who had HCC and who did not have HCC, and the question was the impact of alcohol. 70 people with HCC, 70 people without HCC, and then they went back and asked people, how much do you drink? And they documented that there were people who had heavy drinking versus not heavy drinking, and this was their 2x2 table. And when they calculated the odds ratio, AD divided by BC, it was 3.7, indicating that heavy alcohol use was close to 4 times risk, provides about 4 times the risk of HCC as people who don't drink alcohol. So I hope people don't have seizure disorders. I apologize. So I talked about a lot of things, but let's summarize to a few things. We emphasize research, science is cause-effect relationship. That's what you're doing. Even when you write a case report, that's what you're trying to do, demonstrate cause and effect. So don't lose sight of what research is all about. Interventional studies, Dr. Locke is going to talk about that. It's a randomized control study that has the highest validity. We mainly talked about cohort study and case control study. Cohort study is the strongest of observational studies, but it's difficult to do, expensive, and long study duration. Case control studies is an alternative. It's a lot easier to do. However, but there are pitfalls that I didn't go into the details. In order for your case control study to be valid, there are a few things that you need to make sure. Then we can talk about that if you have questions. But you need to read more about case control studies and make sure that you follow the assumptions that are embedded in the study concept. So I hope this is helpful, and I'm going to transition to the next speaker, unless you have questions. Anybody with questions?